Okay, it's euthyroid 6 syndrome. Thyroid functions are often abnormal in patients with severe acute illness. Severe illness is associated with decreased peripheral 5' deiodination of the T4 to T3 due to caloric deprivation, increased glucocorticoid and inflammatory cytokine release, and inhibitors of 5' monodeiodinase free fatty acid. The most common pattern is low total and free T3 levels with normal T4 and TSH, often called euthyroid 6 syndrome. However, many experts consider this is a misnomer and believe it represents a mild transient central hypothyroid state that serves as an adaptive response to severe illness. If underlying illness continues, T4 and TSH level may eventually decrease. In general, thyroid function testing is in hospitalized patients should be avoided. However, it may be necessary in certain circumstances to rule out hyperthyroidism in acute atrial fibrillation. When euthyroid 6 syndrome pattern is found, thyroid hormone supplementation does not improve clinical outcomes and is not indicated. During recovery, patients may experience modest transient increase in TSH, which may be misinterpreted as subclinical hypothyroidism. Therefore, follow-up testing should be delayed until the patient return to the baseline health. Okay. It's SGLT 2 inhibitor. Okay. I'm reading the box first. Pharmacological management of cardiovascular risk in type 2 diabetes mellitus. Pharmacological management. Antiplatelet known ASCVD or high ASCVD risk. Low dose aspirin 75 to 182 milligram of aspirin. Blood pressure management target is less than 130 by 80. AC inhibitor ARB preferred. Statin therapy known as ASCVD. Age 40 to 75 and age 20 to 39 with increased ASCVD risk. Glucose lowering therapy known ASCVD or age more than 55 with two or more additional risk factor. SGLT2 inhibitor or GLP-1 agonist and heart failure SGLT2 inhibitors. Okay, this patient with type 2 diabetes mellitus has poor glycemic control, HbA1c more than 7%. Despite metformin monotherapy, he has significant comorbidities include coronary artery disease, recent myocardial infarction, obesity. Therefore, pharmacological regimen should be optimized to both address the patient's comorbid condition and improve Glycemic control. The following anti-diabetic medication has been shown to reduce cardiovascular mortality and induce weight loss. SGLT2 inhibitors, canagliflozin and empagliflozin, causes increased urinary glucose excretion and are associated with low systemic and intraglomerular pressure. Additional benefits include reduced progression of nephropathy, modest weight loss, and reduced hospitalization for heart failure. And GLP-1 receptor agonists, semaglutide, liraglutide, show gastric emptying, suppress glucose secretion, increase glucose-dependent insulin release with a strong glycemic efficacy and significant weight loss. These two anti-diabetic medication classes also carry a low risk for hypoglycemia, and either it would be appropriate for this patient. Okay. BMI is very low. Anorexia. BMI is less than 18, isn't it anorexia? These patients low BMI and distorted body image suggestive of anorexia nervosa. Weight loss and chronic malnutrition lead to dysfunction in multiple organs. This patient's clinical presentation of dry skin. This patient's clinical this patient's clinical presentation of dry skin causing scratching and excoriation, edema, abdominal distension, hyperactive bowels, and vital sign abnormality, hypotension, bradycardia is consistent with of medical complication due to anorexia nervosa. Gastroparesis and abdominal bloating are common. Edema is caused by electrolyte and fluid disturbance and is commonly seen in ankles and around eyes. Decreased bone mineral density is due to combination of factors including various endocrine abnormalities, hypercortisolism, growth hormone resistance that result in increased risk of bone fracture. Other complications include hypercarotenemia, accelerated metabolism of cholesterol leading to hypercholesterolemia, cardiac atrophy, arrhythmia, amnesia, lanugo, and seizure. We have done this question just now. Next. This patient's presentation suggested DK. This patient's presentation suggests DK from new onset type 1 diabetes mellitus. Likely DK was likely triggered by her recent GI illness, nausea, vomiting, with exacerbated dehydration and precipitated ketosis. Features of present illness consistent with DK include young age. Although type 1 diabetes mellitus is classically associated with childhood onset, one-fourth of new cases are diagnosed in young children. DK is the second common initial presentation of type 1 diabetes mellitus. DK is the second most common type 1 diabetes mellitus. Rapid onset weight gain, rapid onset weight loss, polydipsia, increased thirst, and diffuse abdominal pain occurs possibly from acidosis, and electrolyte abnormalities impair GI function. Impaired GI function. Clinical signs: dehydration evidenced by tachycardia and hypertension and hyperventilation, compensation for metabolic acidosis. Therefore, checking fasting glucose is the most appropriate next step in the management. This test is rapid and minimally invasive. It can narrow the differential diagnosis and initial treatment for GI symptoms and lethargy. Glucose levels 300 to 800 mg per dl should prompt empiric treatment for DK and confirmatory testing serum ketone and ABG. Okay. Is it due to opioid? Normal value of LH and prolactin is 6. Okay. Oh, okay, this patient has secondary hypogonadism presenting with libido, erectile dysfunction, and low serum testosterone level. Low serum testosterone level. Secondary hypogonadism can be differentiated. Secondary hypogonadism can be differentiated from primary hypogonadism by a low or inappropriately normal LH. In primary hypogonadism, the elevated gonadotropin LH levels stimulate aromatization of estrogen precursor androstenedione from the adrenal gland, leading to gynecomastia. In contrast, breast enlargement in secondary hypogonadism is less prominent. Secondary hypogonadism is a common adverse effect of opioids. Opioids suppress the GnRH and LH secretion, leading to reduced Leydig cell testosterone synthesis, decreased spermatogenesis, and testicular atrophy. Additional manifestation can include depression, hot flashes, osteoporosis. In women, menstrual irregularities are common. Do you want me to read the other options too? Hi. TSH is very low, T4 is free, T4 is high. So it's hyperthyroidism. They they do not say proptosis or pretty will make eczema. We will observe. Okay. This patient has Graves' disease presenting with primary hyperthyroidism, elevated thyroid hormone levels, suppressed TSH, diffuse goiter, and a homogeneously increased radioiodine uptake. Initial management of hyperthyroidism include beta blocker to control hyperadrenergic symptoms, palpitation, tachycardia. In the hyperthyroid phase in GD can be corrected with thiamine, antithyroid drugs, methimazole, radioactive iodine, and or thyroidectomy. In older patients aged more than 65, especially those with cardiac comorbidities, congestive heart failure, as in this patient, antithyroid drugs are favored for initial treatment because radioiodine uptake can transiently worsen hyperthyroid symptoms and may be poorly tolerated. Once the patient returns to euthyroid state, radioiodine intake can be considered, or the antithyroid drug may be continued for long-term management. Okay. Why you choose hypoalbuminemia? In after correction, if calcium level is normal, that means it is hypoalbuminemia. Okay, this patient has symptomatic hypocalcemia associated with significant hypomagnesemia and hypophosphatemia. Hypomagnesemia is very common in hospitalized alcoholic and can cause hypocalcemia by inducing resistance to parathyroid hormone as well as by decreasing PTH secretion. This the cause of hypomagnesemia in alcoholics is multifactorial and may include urine losses, malnutrition, acute pancreatitis, and diarrhea. The patient has additional features of malnutrition or malabsorption, include anemia and mild hypoalbuminemia. Hypocalcemia due to hypomagnesemia is typically with refractory to treatment with calcium unless magnesium is replaced well. Although PTH level increases rapidly after magnesium replacement, hypocalcemia takes longer to improve because PTH resistance persists despite improvement in magnesium level. Despite PTH deficiency, phosphorus levels are normal or low phosphorus levels are normal or low in magnesium deficiency. This is possibly due to intracellular phosphorus depletion. Okay, okay. This is the glucose 6 phosphatase deficiency. Type 1 glycogen storage disease or von Garke disease is caused by deficiency of glucose 6 phosphatase in liver, kidney, and intestinal mucosa. This results in impaired conversion of glycogen to glucose, leading to glycogen accumulation in the affected organ. Patients typically present at 3 to 4 months with hypoglycemia and lactic acidosis. Other lab findings include hyperuricemia and hyperlipidemia. Physical examination demonstrates a doll-like face and a round cheeks, thin extremity, short stature, and a protuberant abdomen due to hepatomegaly. The spleen and heart are not involved. Okay. High phosphorus is normal. Oh, He has recurrent kidney stone. Okay. Causes of hypercalcemia can be categorized on the basis of parathyroid hormone level as PTH dependent or independent. PTH dependent hypercalcemia, suppressed PTH is typically PTH dependent hypercalcemia is usually due to malignancy, vitamin D toxicity, or external conversion of 25 to 125 granulomatous disease. And PTH dependent elevated or inappropriately normal PTH is primary hyperparathyroidism. This patient has hypercalcemia with an elevated PTH level such as parathyroid hormone related peptide. Normally elevated plasma calcium suppresses PTH secretion. However, in parathyroid hormone related peptide, PTH secretion from autonomously functioning parathyroid adenoma or parathyroid hyperplasia is not suppressed. Most patients with parathyroid hormone related peptide present with mild asymptomatic hypercalcemia, but potential clinical features include nephrolithiasis, osteoporosis, nausea, constipation, neuropsychiatric symptoms, stones, bones, cones, psychiatric overtones. Serum phosphorus is often normal but can be low in moderate to severe or parathyroid hormone related peptide. Or primary hyperparathyroidism. Okay, can we stop here? My we can do it by ourselves. We will start hematology tomorrow. Okay. Okay. Bye bye.